Hello, everyone, and welcome to the AI Talk series with New Tigers, a show where we explore the benefits of Edge AI. I am Stan Bertolud, VP of Growth here at New Tigers. I see quite a few people already streaming, and I would love you to use the chat panel to tell us where you are connecting from today. Also, I want this event to be totally interactive. So at any time, feel free to use the chat panel to ask us any question you have on mental health and on AI. So obviously, the COVID-19 pandemic has made us very aware of the importance of mental health. Mental health has become a central topic from corporation HR department to education board. So here at New Tiger, we are developing the next generation of care transformation platform to improve care management of major chronic disease. We believe that by combining non-invasive wearable medical sensors with advanced edge AI analytics, we can provide clinicians with augmented decision aid tools to help them deliver proactive, preventative, and cost-effective care for their patient. As for mental health, New Tiger is leveraging the work of and proof of concept of its co-founder, Professor Jha from Princeton University, and on mental health disorder, and the exclusive IPs on Edge AI analytics to develop innovative predictive tools for major depression, bipolar disorder, and schizophrenia. We are now working closely with Don Parker's organization, Hackensack Meridian Health or Career Clinic, to expand on Professor Jha's initial work and to productize them. So here with me today to talk about AI and mental health, Princeton University Professor Jha and Donald J. Parker, a licensed clinical social worker, President, Behavioral Healthcare Transformation Services, Integrative Medicine for Hackensack Meridian Health, which includes 5 hospital-based general psychiatric services in 11 hospitals and multiple outpatient services. Don also serves as President of Career Clinic here in Princeton. Welcome to the AI Talk series, Niraj and John and Don, and let me get you to the stream. Here we go. How are you guys?
Great.
Great.
Do you want to add anything about your introduction?
No, other than we are probably in the most challenging time ever in my 46 years in behavioral health.
Well, yeah, and as I mentioned in the introduction, we are definitely in the middle of a mental health crisis, which is impacting your industry. Obviously, do you want to say anything about that, Don?
Yeah, let me just give you a frame of reference. You know, the closest episode in our history to what we've just gone through with COVID is the Spanish flu. Spanish flu, we didn't have as many ways to combat it, so it had to actually work its way through our system. So it took multiple years. But suicidality as a proxy for mental health issues didn't peak until 3 years after the eradication of the disease. And it is for a forbidding kind of thought to say that we are not at the peak of the mental health impact of what we've gone through with COVID, and that we should expect multiple years of impact from all the different factors of isolation, of fear, of the contention, mask or no mask, all the emotions that have been wrapped up in this disease will continue to play out on the stage throughout our world over the next several years.
Niraj, I mean, as I said, you were really at the forefront of this proof of concept of bringing AI into mental health. You know, in a nutshell, what trends do you see today happening when it comes to digital mental health?
Well, as Don mentioned, The COVID epidemic has really exacerbated the mental health problem due to our isolation, due to our not being able to meet our friends and family that frequently. So the trends I see and that become more relevant in the current crisis are fourfold. One is diagnosis of mental health conditions, so bipolar disorder, anxiety, PTSD, schizophrenia, and depression, and so on. And we'll talk more about how we can use wearable medical sensors that are embedded in our smartwatches and smartphones to do this diagnosis. A second trend, second important problem is differential diagnosis. So if you look at some mental health conditions like bipolar disorder, depression, they have an overlap. There some symptoms overlap. So how do you distinguish between different mental health disorders? That would be differential diagnosis. Third, we assume that we've done the diagnosis and then we want to keep the individual, the patient well. They've gone home, and but sometimes they may suffer from extreme episodes of depression or anxiety or whatever the condition is. So it would be good to have the psychiatrist know in real time that this person needs an immediate intervention. So if the diagnosis from the smartwatch and the smartphone is getting uploaded into the health server in the psychiatric clinic, then that would become possible. So, trying to keep your patient well most of the time, that would be something that psychiatrists and psychologists would love. And the technology now exists for making that happen. And the fourth thing I see is decision making, which is the diagnosis has been done, and there is a person, a patient that has come to the clinic, and the question is, what is the optimal intervention? Is it cognitive behavioral therapy? Is it drug one? Is it drug two? Is it doing nothing, just chatting with the individual? So what is an optimal diagnosis followed by optimal decision making? And this decision making should be personalized, because what is good for me may not be good for another individual. So these are some of the trends that I see that will become part of digital psychiatry going forward, and we can discuss that in more detail later on.
Absolutely, and thank you for this introduction to our topic, Don and Niraj. Yeah, I mean, we definitely went through an incredible health crisis, which, as you said, is far from being over, which has changed the industry. Niraj, you showed that digital and AI will play a role now on. I would love to hear from both of you, what use cases do you see when it comes to digital mental health and the use of AI? Don, do you want to start?
Sure. I think that Dr. Niraj's comment about the ability to give precise diagnosis as opposed to what happens today. We look at a constellation of symptoms while you're in our hospital. And generally there are multiple different individuals opining on your particular condition. And then we try to gather that information together, and it's an imprecise process that we go through to get a diagnosis. While you're in the hospital, we then follow that diagnosis. We provide medication that's particular for that diagnosis. We see how it impacts on you. We titrate, we add, we do a whole variety of different things to adjust your medications. And then we hope to get a progressive improvement over the time you're with us. And the lack of science in that process, one, makes it a very difficult process for the patients to go through because the changes that are made during the process, and our medications have different side effects. They have different immediate effects on our patients. And then secondly, the lack of precision in that process oftentimes leads to a patient leaving us and having to come back in shorter periods of time for adjustments to that medication or adjustments to offset the side effects. So the entire process is too lengthy, too complex right now, and oftentimes leads to significant additional cost and challenges for the families that are working their way through an episode of this. So put that together, we are really desperate for better diagnostic services, more precision in that process to make this an outcome-driven and a cost-effective treatment modality.
Yeah, so as Don mentioned, there is a bit of a trial and error process in this process of doing diagnosis and figuring out what interventions to make. So AI and ML could help in the following way. So the hypothesis is that the condition, the mental health disorder, leaves a signature on the physiological signals that emanate from your body. For example, your skin conductance, skin temperature, could be heart rate, pulse oximetry, could be blood pressure. So there are lots of signals that are emanating from our body that can be caught with these wearable medical sensors that are increasingly getting integrated into smartwatches and smartphones. And the hypothesis is that that signature that the condition leaves on these physiological signals is unique to that particular condition. And it is possible to distinguish one condition from another, in addition to distinguishing that condition from the healthy status. And that's something that we have shown in a framework that we call MHDeep, for mental health deep. Deep stands for deep learning. We use neural networks to be able to do this diagnosis. And then, as I mentioned earlier, after you've done the diagnosis, and sometimes you have a neural network for depression, another neural network that has been trained for bipolar disorder, and both of them may be saying that this person has this condition. So now you have to distinguish the two. And so there's another neural network that you can use to do the differential diagnosis. So that's something we are trying to incorporate into the workflow, and with Don's help. And I would like to point out that 5 years ago, when we pitched this idea in 2017, I remember it was summer of 2017, my PhD student Hong Shu In and I went over to Career Clinic in Belmead. It's about 8 miles from Princeton University. And we pitched this idea to Don, and Don immediately saw the implication and the application of this in the digital psychiatry workflow. So one of the first people who appreciated this idea, although we've had a lot of pushback on our idea from elsewhere, but Don could see it within a minute that this idea could work. And so now, 5 years later, we are in the process of trying to validate this approach with field trials with the help of Don's organization.
Thank you. Thank you, Dr. Cha. Let me comment a little bit about the relationship, and it was at a very interesting introduction. I actually started at Carrier about 10 years ago, and it kind of dawned on me several years into the business that we had an enormous resource down the street. I'm not sure why it took me so long, but Princeton is one of the few Ivy League schools that doesn't have their own hospital, and that may be a benefit because you don't have the bureaucracy of a hospital to have to worry about all the time and all the challenges of that. On the other hand, it does limit the interactive research that goes on between the faculty and the healthcare delivery system. And so I raised my hand to say we'd be glad to be a healthcare delivery system for Princeton. And actually, over the years, we had done some work with Princeton early in the 70s. And had some very successful collaborative activities, and then it just kind of faded away. And so we got back at this. Professor John, his student came. We looked at the process, determined that especially in our acute care units, this would be of enormous value. That's where at no pun intended, that's where the deep activity takes place in the psychiatric hospital. And we are looking, we are exploring generally with patients who have had multiple chronic episodes, and we are coming usually to the end of our resources in terms of solutions for that. The AI and the introduction of precision into that process, and then the ability to monitor patients, which would help us have a major impact on the patients' lives and then our readmission rate and the reputation that Carrier has for being able to bring unique and innovative solutions and effective solutions to our patients.
Yeah, so what Don's organization enabled for us was the process is you put a smartwatch on your wrist, put a smartphone in your pocket, and it's about 1.5 hours of data collection. The sensors, they have different frequency, 1 hertz, 4 hertz, and so on. They're collecting data at that rate. And once the data have been collected for 1.5 hours per individual, and you collect it from many individuals, and the expert, the psychiatrist, will tell us this person has this disorder. And after they've figured out after maybe days or weeks of examination that that diagnosis is correct. So that becomes a label for the data that we've collected. And then you train a neural network with all this data, and you collect data from healthy individuals as well to be able to distinguish disorder from healthy. But once the neural network is ready, what you do is you encapsulate that into an app. That app you download that is on your smartphone. And now your smartphone gets the data from your smartwatch wirelessly, and some sensors may be on your smartphone. So that data is already available to the smartphone. And then within minutes, it does a diagnosis. Now, for example, let's take the diagnosis for depression. It's possible that we may be depressed for some reason. Maybe something happened to our pet. Maybe my paper got rejected. So maybe for a day I'm not feeling great. But that depression or that feeling of being low does not last that long. So if every few minutes you get this diagnosis from your smartphone app, you can look at the probability. It outputs a probability also. And if that probability is high and sustained, then the app could say that you should go and see a professional. But if it is just, it goes up someday and then comes down the next day, then it was some other event that caused you some depression, some anxiety on the previous day, on that day, but the probability is going down. So then you don't have to worry that much. So all of this information you can get locally on your smartphone, and you are in control. That diagnosis does not have to be sent to the cloud. So it maintains your privacy and maintains your security. So those are some of the advantages of doing this locally with your smartphone app.
And then we applied this process inside of our acute care units with a very, very controlled environment. We actually have 2 look-alike acute care units, 20-bed units, and it gives us the opportunity to apply in a experimental fashion different approaches to both identifying and managing psychiatric illness. So, and when Dr. Jha showed up and with this opportunity, we had an eager staff as well as some very, very interested patients in getting, again, more precision into the diagnostic process, and then the potential for being able to monitor themselves post-hospitalization for any potential for relapse, and to catch the relapse instead of in an advanced stage and at a stage where we could take very quickly applied and we hope more effective means of recovery.
Yeah, Don, I was wondering, what has been the feedback from the patient?
Well, patients are one, amazed because we speed up the diagnostic process. Generally, our patients come in and they're several days in a diagnostic phase with us. Using this system, we can speed that up. We're still looking at how quickly we can do it, but we are getting very, very quick in being able to do the diagnosis. And then the prospect of being able to avoid a readmission for almost any chronic patient or patient with a serious mental health disease is a godsend.
We are going to touch on that in a minute, but yeah.
So
okay. Sorry, I want to remind everybody streaming this event that we would be happy to take your questions. So feel free to ask any question, comment using the chat panel, and we'll get back to you. So yeah, Don, and I think you were about to start on that. I would love you to tell us about some of the challenges of integrating AI into clinician workflow and the impact it may have on your industry.
Well, first of all, the industry itself is going to be going through radical change. We're going to talk a little bit about that before we're done, and just the sheer demand that we're going to have to manage. And then, fortunately, the advent of technology to assist us in that process in any number of ways. And we've woven technology very deeply into the fabric of the carrier clinic. And so when you get a tool like Dr. Jha is bringing to the table that really gets at areas where we haven't had a lot of technology innovation, like the diagnostic process, and again, back to my comments on the lack of precision in that process, it really changes the whole way that you handle a patient coming through the inpatient psychiatric system, and frankly, ultimately into the outpatient world. So I think that this kind of approach, the AI applications, is going to give us a new way to be more efficient, to be more effective, to be more accurate, and to bring precision into the actual treatment strategies that we apply. So that has a potential for helping us to radically change a business that has been slower to change than most other elements of healthcare.
And one thing I'd like to add, Don just mentioned outpatients. So the diagnosis has been done, the patient has gone home. Now you want to keep the patient well while they're at home. And this type of app is, again, helpful because as long as you're wearing the smartwatch and you have the smartphone on you, you have the diagnosis or the current in real-time diagnosis available to you. And even if, assuming the patient has agreed to upload the diagnostic decisions to the health server of the psychiatric clinic, then the psychiatrist also has access in real time to the trend, whether it's depression, anxiety, whatever the disorder that is being monitored is, what the trend is, even though the patient is not in the clinic. And if there is an extreme episode, then that person can be called in for an appointment. So in a way, this technology goes beyond diagnosis and differential diagnosis. And the ultimate aim of a physician is to keep the person well. It's not just treating and diagnosing, but keeping the patient well even when they're back at home. So this technology would also enable that. And as Stan mentioned, MHDeep, this framework has been licensed to New Tigers, and New Tigers is interested in evaluating this wellness scenario as well.
Yeah, if you think about the process of treatment as we complete our work in the hospital and you're released to the community, again, we generally are not able to keep touch with you. So our ability to catch you early on in a relapse becomes more and more important. And how do you do that? How your patients generally aren't communicating with you. You're handing them off to an outpatient facility. Unless that outpatient facility's got the capability, you're not going to see a patient until they're in a very difficult situation. If this allowed us to get you when you're, say, for instance, 25% into a subsequent episode, and we could do what my good friend Patrick Kennedy calls a checkup from the neck up, getting you back out into the community quickly with maybe a one-day stay as opposed to another stay. So I think this has profound impact on chronicity. And our patients, as we know, the farther they get into and the more frequently they get into the mental health system, the more likely it is that they get caught in it.
Yeah, and one more thing I'd like to mention, which I'd mentioned under trends earlier, is decision making. So now you've collected data, 1.5 hours of data from someone who came in, and then an intervention took place. Let's say CBT, some medicine, whatever was the intervention. We record that, and then we take 1.5 hours of data post intervention, and now we have this kind of a trajectory available for many patients that goes into our library. And then a new patient comes along who has not had any intervention, and the question is, what is the optimal intervention for that person? So what we can do is we can take all the data that we've stored in our library and do what is called a synthetic control or synthetic intervention, where you try to match a combination of a bunch of individuals that you have in the library with the new person who's come along, and you try to answer the counterfactual. This patient has not gone through any intervention, but the others have. And so you answer the counterfactual. What would happen if this patient underwent CBT or underwent or took a particular drug? So before you've done that intervention, and you figure out which one will have the most impact, most positive impact, before you make that intervention. So that could be another tool that would be available to the psychiatrist. And we have a paper recently submitted on just that point. So this would also be part of the set of tools that we can make available for psychiatry. Would medical history be considered to determine the outcome? This is a question.
Yeah.
So you can have medical history be part of the training of the neural network in terms of questions that you can ask the patient. So there are these questionnaires that are used for different disorders that psychiatrists use all the time. And so in addition to the wearable medical sensor data that you collect from the smartwatch and the smartphone, you can also have the questionnaires be another part, another data category that you also use to train the neural network. So we've done that for COVID. And so there is a sister framework similar to MHDeep, which we call COVID Deep, that can diagnose COVID, where we take 5 wearable medical sensors plus a questionnaire with 11 questions. So same approach can be applied to mental health as well.
Don, do you want to add anything?
No.
Okay.
No, that's to the point.
Good. Here's another question.
Let's see, I fully support the augmentation of how we, as providers, diagnose mental health. I'm currently integrating robots into nursing homes across Minnesota. My overarching question is, what thoughts do you have behind insurance companies having this level of physiologic data on their customers? And have you explored the ethics of this?
So I would like to add is that the diagnosis resides on your smartphone, and it doesn't have to leave your smartphone. So you're in control of the diagnosis. Who else sees it? Insurance companies need not see it. You need not even upload it to a server anywhere. So you're in control of this diagnosis. So there is a privacy element to it that goes along with the use of these neural networks that are embedded in an app that is residing on your smartphone.
And obviously, a lot of work yet to do on the business model of this innovation and how we deliver it, how we integrate it into our care pathways. And so, for those of you that are already engaged in care pathways, and you are actually have the capability of a significant electronic health record to embed this information, and we expect that we'll have different types of ways of protecting your privacy of your information, as we do your information from the hospital, our electronic information, our written information, and then make sure that, again, as Professor Jha said, talks about you are in charge of that information, and we would train you to understand, read triggers and responses that would ultimately get you the kind of care that you need when you believe you need it. So we'll have at the end a more educated consumer in their behavioral health conditions, which is an area we need to catch up with other disease states.
Right, thanks. So we have another question, and I want to encourage the audience to keep on asking questions. We are getting at the end of this session, but I think we can go slightly over time if need be. Here's a question, and before we take it, I just want to remind everybody again that you can scan this QR code, and it will take you to a link where you, after entering your email address, you will be able to download the study and the report that Professor Jha and his team has been working on. Who wants to take this question?
Yeah, so to what degree is poor medication adherence an impediment to achieving the desired outcomes? So let's look at that scenario where the person is in an outpatient scenario and is not taking the medication that has been prescribed. So what would happen? Let's say it's a depression scenario. What would happen is that the probability for depression from the smart phone app will go up. And if this information, the current probabilities are being uploaded to the health server of the psychiatric clinic, then the psychiatrist knows that something is amiss. Either there is a relapse or there is some, maybe the therapy is not working, maybe the medicine is not working or is not being taken. So in fact, this can be flagged in real time that something is amiss.
I mean, it'd be analogous to handling other disease states like diabetes, where you're constantly monitoring your insulin levels. And in our case, you'd monitor the proxies for the behavioral health condition, and then be able to take the action you need, either yourself or in concert with your physician or other caregivers, to get you the kind of service that you need to address whatever's coming up.
Right. It's interesting you mentioned diabetes, because this is one of the chronic diseases we are working on at New Tiger, as well as sickle cell and other disease. I would love to hear from both of you your vision for these industries in the next 10 years from now. I know 10 years is a very long time away, but what do you see?
Well, I'll take a shot at that. The behavioral health field, as I mentioned before, we've been under-resourced for decades, which has left us, for instance, no meaningful use money, hence either no or less than what we would want from a technology system to help us manage our patient interactions and outcomes and all the things that we do. I took the step to join a health system, and one of those reasons was to get access to a large, very heavily integrated technology system where we could develop clinical pathways for our patients and we could monitor adherence to them. And I also wanted to be able to get experience as a payvider, so that we are a payer and provider. We have our own insurance company, a joint venture with another insurance company. And as a result, we are taking on episodes of care to manage. We are also being able to help get shared savings back to the development of this product, as well as other activities that we're engaged in. So we're going to hopefully follow the path that the rest of healthcare has followed over the last century, and get ourselves into using technology very efficiently and effectively to the benefit of our patients, saving dollars for our patients and helping us provide the money we need to be able to do the work on treatment technology, treatment approaches, treatment outcomes, and have ultimately a better experience for our patients and for our staff.
Yeah, Don, do you want to say a bit more about this new payment that you see, taking place at the moment?
Sure. So as you enter the world of being a payvider, you are making decisions both as an insurance company and a provider. And then in the past, when the insurance company would change regulations to save money, the savings went to the insurance company, not to the provider. It was taken at the deficit of the provider oftentimes. And so today, when we come up with new ways to do business and we do it more efficiently, we have less relapses, we reduce costs, we would have shared opportunities in that, which gives us an incentive to do it. And so I think in this new world, more and more players, whether they're mental health or healthcare, are joining in to larger health systems. We have a large system. We have 17 hospitals, and it gives us a presence. It gives us capability. It gives us resources to train physicians to participate or even initiate our own research. And it allows us to have a major impact on the systems that we operate in a positive way.
Right. And this is where technology comes into
Yes.
play, obviously.
Correct.
Yeah. I want to bring up this question, and I'm conscious of time, so I think we'll have to wrap up pretty soon. Who wants to take this question? Don?
Let's see. It says, could you tell to what degree the questionnaire data added information as compared to the passive measurement and relapse prediction? So what was the exact predictive value of both in terms of sensitivity and specificity? I will opine on this, but I think Professor John would be better on it, because their process is developed to do exactly this, is to get us information. So we get a baseline information when you come in, when you're fluidly psychotic. We know what your vitals are. We can follow the changes in those, and there would be predictable pathways for an individual to go in terms of progress on those vitals. The real beauty for me is once we've gotten your stable vitals, we can then look at those vitals over the long term. And when we see, for instance, a deviation of 25% from the stable values, we could literally contact you and say, hey, Don, we see that you may be having some difficulty. Is there something we can help you with? Can we bring you back in for a checkup? And so as you develop episodes of care and clinical pathways, this tool becomes a critical component of decision-making by the individuals that are both creating and monitoring those pathways, and then ultimately monitoring your health, which is something that the payvider status puts you in a position to do.
Yeah, so I would answer this question with another condition, which is COVID, because we didn't collect questionnaire data for MHD, for the mental health scenario. But in COVID-19, when we were trying to do diagnosis in the same way, we had 5 different sensors plus the questionnaire. So there are 6 data categories. And what we did was, if you take 6 categories and look at all possible subsets, 1 at a time, 2 at a time, 3 at a time, and so on, you have 63 subsets. And we developed neural networks, trained neural networks for all of them to look at the sensitivity, specificity for each. And we found that there was a particular subset with 3 sensors in the questionnaire that performed the best. It had 98% accuracy for COVID-19. Now, going forward, we are going to collect data on anxiety, PTSD, from Career Health Clinic. Don is helping again to enable us to collect that data. We'll do the same thing. So questionnaire is an important data category, but different neural networks have attach different level of importance to each of these categories. And we will see how important questionnaire is with respect to the others. So we just go for the subset of data categories that gives us the highest accuracy, which means good true positives and good true negatives.
Thank you, Niraj. We are 10 minutes past the half an hour. So thank you everyone for attending. Before we go, I know you didn't have a chance, Niraj, to comment on what the future will look like in 10 years from now. Do you want to share your views very quickly?
Sure, yeah, very quick. So I think this is the decade of smart healthcare. And by smart healthcare, I mean AI or machine learning in healthcare. And you can see that by the amount of VC funding that is going to healthcare startups. It's increasing by about 41% per year. It's expected to exceed 100 billion per year within 5 years. So 10 years from now, I would expect there'll be lots of apps available which encapsulate the neural network that does the diagnosis. Based on our family history, based on our genetics, we will download maybe 5 or 10 of them that will monitor us. Maybe we are more susceptible to diabetes or hypertension or depression, whatever is the condition that we, based on family history or genetics, that we are more susceptible to. We will be monitoring them around the clock. So I see that happening, maybe not even 10 years, maybe in 5 years that could happen.
Yeah, let me just add a quick comment on it. So over 300 new applications came out last year alone. And that flurry of interest and the money being invested in behavioral health technology it is going to change our business model. So for those of us who are currently delivering care, we need to begin to think about how we engage in the use of all these tools in our processes, which means a new business model for us. And it could be probably the most radical change that we've undergone in our profession in a century. So it is something that you, if you're not thinking about already, ought to be thinking about. And if you're not delving into the developments that are going on, including what we're talking about today, you need to be doing that.
Thank you both. Thank you, Donald, President of Carrier Clinics and of Hackensack Meridian Health. Niraj Jha, Professor at Princeton University and co-founder of New Tigers. Thank you so much for your time. It was a fascinating discussion, and judging from all the comments, it was well followed and totally appreciated. Thank you. Have a good day.
Thank you, Stan.